Question 1. A patient presents with symptomatic bradycardia unresponsive to atropine. Which medication would be the next appropriate choice according to ACLS guidelines if pacing is not immediately available? A. Adenosine. B. Amiodarone. C. Dopamine. D. Lidocaine. Answer: C. Dopamine. This question tests your knowledge of treating symptomatic bradycardia. The key clue is unresponsive to atropine, indicating a need for a second-line drug before or alongside pacing. Dopamine is an appropriate vasoactive infusion for symptomatic bradycardia if atropine is ineffective and transcutaneous pacing is not readily available or effective, as it increases heart rate and blood pressure. For example, a continuous infusion of dopamine at 2 to 20 mcg/kg/min can be used to stabilize a patient until pacing can be initiated. Remember that dopamine, like epinephrine, helps increase heart rate and myocardial contractility in these critical situations. Question 2. For a patient in stable narrow-complex tachycardia, which medication is typically the first-line pharmacologic treatment? A. Amiodarone. B. Adenosine. C. Diltiazem. D. Lidocaine. Answer: B. Adenosine. This question focuses on the initial management of stable narrow-complex tachycardia. The key is stable narrow-complex tachycardia, which points directly to adenosine as the first-line treatment for its ability to temporarily block the AV node and reveal or terminate reentrant pathways. A rapid forepush of 6 mg adenosine followed by a flush is the standard initial dose to interrupt the circuit. Understanding adenosine's role in slowing AV nodal conduction is crucial for managing these specific arrhythmias. Question 3. What is the recommended initial dose of intravenous for atropine for symptomatic bradycardia? A. 0.25 mg. B. 0.5 mg. C. 1 mg. D. 2 mg. Answer: B. 0.5 mg. This question assesses your recall of the correct initial dosage for atropine in symptomatic bradycardia. The phrase initial dose is a direct prompt for the first step in treatment. The recommended initial dose of atropine is 0.5 mg, which can be repeated every 3 to 5 minutes up to a maximum total dose of 3 mg. This dose helps to block vagal effects on the heart, thereby increasing heart rate. For instance, if a patient has a heart rate of 40 bpm with hypotension, 0.5 mg of atropine is the first drug to administer. Always remember that atropine's maximum dose is 3 mg. Question 4. A patient in refractory ventricular fibrillation, VF, after initial defibrillation and epinephrine administration may benefit from which antiarrhythmic drug? A. Atropine. B. Adenosine. C. Amiodarone. D. Diltiazem. Answer: C. Amiodarone. This question tests your knowledge of antiarrhythmic drugs used in cardiac arrest. The key phrase refractory ventricular fibrillation after initial defibrillation and epinephrine points to the need for an antiarrhythmic. Amiodarone is the preferred antiarrhythmic drug for refractory VF/pulseless VT, with an initial 4/IO dose of 300 mg. This medication helps to stabilize the heart's electrical activity and make defibrillation more successful. For example, if a patient remains in VF after 2 shocks and epinephrine, amiodarone is the next drug to consider. Think of amiodarone as a potent agent for stubborn ventricular arrhythmias. Question 5. What is the primary indication for the use of magnesium sulfate in ACLS? A. Symptomatic bradycardia. B. Atrial fibrillation. C. Torsades de pointes. D. Stable narrow complex tachycardia. Answer C. Torsades de pointes. This question specifically asks about the primary indication for magnesium sulfate in an ACLS setting. The crucial concept here is understanding magnesium's role in specific ventricular arrhythmias. Magnesium sulfate is the drug of choice for treating polymorphic ventricular tachycardia known as torsades de pointes, especially when associated with a prolonged QT interval. For example, a patient displaying a distinctive twisting of the points on the ECG would promptly receive 4 magnesium sulfate to stabilize their heart rhythm. Always remember magnesium for its specific role in treating this unique and dangerous type of VT. Question 6. What is the recommended dose of epinephrine for adult cardiac arrest? A. 0.1 mg 4/IO every 3 to 5 minutes. B. 0.5 mg 4/IO every 3 to 5 minutes. C. 1 mg 4/IO every 3 to 5 minutes. D. 2 mg 4/IO every 3 to 5 minutes. Answer C. 1 mg 4/IO every 3 to 5 minutes. This question directly assesses your knowledge of epinephrine dosing in cardiac arrest. The keyword cardiac arrest specifies the critical scenario. The standard dose of epinephrine for adult cardiac arrest is 1 mg administered intravenously or intraosseously every 3 to 5 minutes throughout the resuscitation effort. This potent vasoconstrictor helps improve coronary and cerebral perfusion during CPR, increasing the chances of return of spontaneous circulation. Always remember that epinephrine is a cornerstone drug in all cardiac arrest rhythms. Question 7. What is the appropriate initial 4/IO dose of lidocaine for refractory ventricular fibrillation/pulseless ventricular tachycardia when amiodarone is not available or contraindicated? A. 0.5-0 75 mg/kg. B. 1:1 5 mg/kg. C. 2-3 mg/kg. D. 3-4 mg/kg. Answer B. 1:1 5 mg/kg. This question tests your knowledge of alternative antiarrhythmic drugs for cardiac arrest. The keywords refractory VF/pulseless VT and amiodarone not available or contraindicated guide you to lidocaine as a secondary option. The recommended initial 4/IO dose of lidocaine for this scenario is 1:1 5 mg/kg, which can be followed by a second dose of 0.5-0 75 mg/kg in 5 to 10 minutes, up to a maximum total dose of 3 mg per kilogram. Lidocaine works by suppressing ventricular ectopy and increasing the ventricular fibrillation threshold. Remember lidocaine as a backup choice when amiodarone cannot be used for ventricular arrhythmias in arrest. Question 8. A patient is in sinus bradycardia with signs of poor perfusion. After administering atropine, the heart rate remains low, and the patient's condition does not improve. Which medication might be used as a continuous infusion? A. Adenosine. B. Norepinephrine. C. Epinephrine. D. Diltiazem. Answer C. Epinephrine. This question asks about managing symptomatic bradycardia that is unresponsive to atropine. The key phrases sinus bradycardia with signs of poor perfusion and atropine condition does not improve point to the need for a vasopressor. Epinephrine, specifically a continuous infusion at 2 to 10 mcg/min, is a suitable alternative to dopamine or transcutaneous pacing for symptomatic bradycardia that does not respond to atropine. It helps to increase both heart rate and blood pressure by stimulating beta-1 and alpha-1 receptors. For instance, if pacing is unavailable, an epinephrine infusion can bridge the gap until definitive treatment is possible. Question 9. In the treatment of acute coronary syndrome, ACS, what is the typical initial dose of aspirin, non-enteric coda D, for a patient without contraindications? A. 81 mg chewable. B. 162 mg chewable. C. 325 mg chewable. D. 650 mg chewable. Answer, C. 325 mg chewable. This question focuses on the initial drug therapy for acute coronary syndrome. The key is initial dose of aspirin in the context of ACS. For patients presenting with ACS symptoms and no contraindications, a chewable dose of 162 mg to 325 mg of aspirin is recommended immediately, as it inhibits platelet aggregation and can improve outcomes. Administering 325 mg chewable aspirin is often the preferred choice to achieve rapid absorption and antiplatelet effect, helping to prevent further clot formation in the coronary arteries. Always remember to give aspirin as early as possible for suspected heart attacks. Question 10. Which medication is used to treat paroxysmal supraventricular tachycardia, PSVT, if adenosine is ineffective or contraindicated, and the patient remains stable? A. Lidocaine. B. Procainamide. C. Diltiazem. D. Atropine. Answer, C. Diltiazem. This question addresses treatment options for PSVT when the first-line drug fails. The keywords PSVT, adenosine is ineffective or contraindicated, and patient remains stable indicate a need for a rate-controlling agent. Diltiazem is a calcium channel blocker used to slow the ventricular rate in stable supraventricular tachycardias, including PSVT, when adenosine isn't working or is inappropriate. For example, after an unsuccessful attempt with adenosine, a bolus of diltiazem might be administered to slow a rapid heart rate down. Remember that diltiazem controls rate, which is often the goal in stable tachycardias. Question 11. What is the primary role of sodium bicarbonate in ACLS? A. Routine use in all cardiac arrest. B. To treat documented severe metabolic acidosis. C. To correct hypokalemia. D. To reverse the effects of beta blocker overdose. Answer, B. To treat documented severe metabolic acidosis. This question explores the specific indications for sodium bicarbonate in cardiac arrest. The concept being tested is the appropriate use of this drug, not its routine use. Sodium bicarbonate is not routinely recommended during cardiac arrest but can be considered for specific situations like documented severe metabolic acidosis, hyperkalemia, or tricyclic antidepressant overdose. It works by buffering the acidosis, which can improve the effectiveness of other resuscitation efforts. For instance, if blood gas analysis shows profound acidosis, bicarbonate might be administered. It's crucial to understand its limited and specific indications. Question 12. A patient with suspected inferior wall myocardial infarction is experiencing chest pain. Before administering nitroglycerin, what should be assessed? A. Blood glucose level. B. Renal function. C. Blood pressure. D. Heart rhythm. Answer, C. Blood pressure. This question highlights a critical safety check before administering a common cardiac medication. The key here is before administering nitroglycerin, which is a potent vasodilator. Nitroglycerin causes vasodilation and can significantly lower blood pressure, which could be dangerous, especially in patients with right ventricular infarction. Therefore, assessing the patient's blood pressure is essential to ensure it is within an acceptable range, e.g., systolic BP greater than 90 to 100 millimeters of mercury, before administration. Always check blood pressure before giving nitroglycerin to prevent profound hypotension. Question 13. Which medication is contraindicated for a patient presenting with acute cocaine-induced chest pain? A. Aspirin. B. Nitroglycerin. C. Morphine. D. Beta blockers. Answer: D. Beta blockers. This question tests your awareness of specific drug contraindications in acute coronary syndromes with a particular etiology. The key phrase, cocaine-induced chest pain, is crucial. Beta blockers are generally contraindicated in cocaine-induced chest pain or acute coronary syndrome because they can lead to unopposed alpha-adrenergic stimulation, worsening vasoconstriction, and potentially increasing myocardial ischemia or infarction. Aspirin, nitroglycerin, and benzodiazepines are preferred treatments. Remember to avoid beta blockers in patients presenting with cocaine use. Question 14. For a patient in pulseless ventricular tachycardia, private, or ventricular fibrillation, VF, after initial defibrillation and epinephrine, what is the initial 4/IO dose of amiodarone? A. 150 milligrams. B. 300 milligrams. C. 450 milligrams. D. 600 milligrams. Answer: B. 300 milligrams. This question assesses the correct initial dosing of amiodarone in cardiac arrest. The keywords pulseless VT or VF and after initial defibrillation and epinephrine indicate the timing for the first dose of an antiarrhythmic. The initial 4/IO dose of amiodarone in refractory private/VF is 300 milligrams, which can be followed by a second dose of 150 milligrams if the arrhythmia persists. Amiodarone helps to stabilize the myocardial cells and improve the likelihood of successful defibrillation. Knowing this specific dose is essential for effective cardiac arrest management. Question 15. A patient presents with torsades de pointes. What is the recommended initial dose of magnesium sulfate? A. 0.5-1 g/IO. B. 1 to 2 g/IO. C. 2 to 4 g/IO. D. 4 to 6 g/IO. Answer: B. 1 to 2 g/IO. This question focuses on the correct dosage of magnesium sulfate for its primary indication. The specific rhythm, torsades de pointes, is the key to identifying the treatment. The recommended initial 4/IO dose of magnesium sulfate for torsades de pointes is 1 to 2 g, typically diluted in 5 to 10 milliliters of D5W and given over 5 to 20 minutes, depending on the presence of a pulse. This drug helps stabilize the cardiac membrane and reduce the likelihood of recurrence of this specific polymorphic VT. Remember to administer magnesium slowly, especially if the patient has a pulse. Question 16. What is the recommended post-cardiac arrest care target for mean arterial pressure, MAP? A. Greater than 55 millimeters of mercury. B. Greater than 60 millimeters of mercury. C. Greater than 65 millimeters of mercury. D. Greater than 70 millimeters of mercury. Answer: C. Greater than 65 millimeters of mercury. This question tests your knowledge of hemodynamic goals in post-cardiac arrest care. The concept is maintaining adequate perfusion after return of spontaneous circulation, RO-SCI. The target mean arterial pressure, MAP, in post-cardiac arrest care is generally greater than 65 millimeters of mercury to ensure adequate organ perfusion and prevent secondary brain injury. If the patient's blood pressure falls below this target, vasopressors like norepinephrine or dopamine should be considered. Maintaining a good map is crucial for patient recovery following cardiac arrest. Question 17. Which medication is used to increase heart rate and myocardial contractility during bradycardia that is unresponsive to atropine and pacing? A. Lidocaine infusion. B. Norepinephrine infusion. C. Adenosine infusion. D. Dobutamine infusion. Answer B. Norepinephrine infusion. This question asks about the management of persistent symptomatic bradycardia. The keywords bradycardia, unresponsive to atropine and pacing, and increase heart rate and myocardial contractility point toward a vasopressor with inotropic effects. While epinephrine and dopamine are often first-line choices in this situation, norepinephrine infusion, at 2 to 10 mcg/min, is also an appropriate second-line vasopressor that can improve both heart rate and blood pressure by its strong alpha and beta-1 agonism. For example, if a patient remains hypotensive and bradycardic despite initial treatments, norepinephrine can help stabilize hemodynamics. Question 18. What is the most appropriate initial treatment for a patient in unstable wide complex tachycardia with a pulse? A. Amiodarone 300 mg 4. B. Adenosine 6 mg 4. C. Synchronized cardioversion. D. Lidocaine 1, 5 mg/kg/4. Answer C. Synchronized cardioversion. This question assesses the critical initial intervention for an unstable rhythm. The keywords unstable wide complex tachycardia with a pulse are the most important clues. Any patient with an unstable tachycardia, meaning they have signs/symptoms of poor perfusion like hypotension, altered mental status, signs of shock, or acute heart failure, requires immediate synchronized cardioversion regardless of the rhythm's specific morphology. This electrical therapy is faster and more effective at restoring a stable rhythm than any drug in an unstable patient. Remember, unstable patient, immediate cardioversion. Question 19. What is the first-line medication to consider for an adult patient experiencing a STEMI, after oxygen and aspirin, if chest pain persists and blood pressure is adequate? A. Morphine. B. Furosemide. C. Heparin. D. Nitroglycerin. Answer D. Nitroglycerin. This question tests the initial pharmacological management of acute coronary syndrome. The keywords STEMI, chest pain persists, and blood pressure is adequate point to nitroglycerin as the next step after initial interventions. Nitroglycerin is a potent vasodilator that helps relieve chest pain by reducing myocardial oxygen demand and increasing coronary blood flow. It can be given sublingually, 0, for mg, every 3 to 5 minutes for up to 3 doses, or as in 4 infusion. For example, if a patient's chest pain hasn't resolved with aspirin, nitroglycerin is the go-to to further alleviate the symptoms. Question 20. When managing acute pulmonary edema and hypertension, which medication can rapidly reduce both preload and afterload? A. Dopamine. B. Norepinephrine. C. Nitroglycerin. D. Atropine. Answer C. Nitroglycerin. This question focuses on the utility of nitroglycerin beyond chest pain. The key phrases are acute pulmonary edema and hypertension, highlighting a need for a drug that reduces cardiac workload. Nitroglycerin, when given intravenously as an infusion, is effective in acute pulmonary edema because its potent venodilation reduces preload, reducing fluid in the lungs, and its arterial dilation reduces afterload, making it easier for the heart to pump against lower resistance. This dual action helps to improve cardiac function and lung congestion. Think of 4-nitroglycerin as a powerful tool to rapidly alleviate cardiac strain in these hypertensive emergencies. Question 21. For a patient with a confirmed opioid overdose presenting with respiratory depression, what is the recommended initial dose of naloxone? A. 0, 1 mg 4/IM/IN. B. 0, 4 mg 4/IM/IN. C. 1 mg 4/IM/IN. D. 2 mg 4/IM/IN. Answer B. 0, 4 mg 4/IM/IN. This question tests your knowledge of specific antidote medications. The keywords opioid overdose and respiratory depression clearly indicate the need for naloxone. The recommended initial dose of naloxone for opioid overdose with respiratory depression is 0, 4 mg 4 IM, or intranasal, which can be repeated every 2 to 3 minutes as needed. This opioid antagonist rapidly reverses the effects of opioids, restoring respiratory drive. For example, if a patient is unresponsive and breathing slowly after suspected opioid use, naloxone is the immediate life-saving drug to administer. Question 22. Which antiarrhythmic drug is contraindicated in patients with prolonged QT interval? A. Lidocaine. B. Amiodarone. C. Procainamide. D. Metoprolol. Answer C. Procainamide. This question focuses on an important contraindication for a specific antiarrhythmic. The keyword prolonged QT interval is the crucial clue. Procainamide, while an effective antiarrhythmic for some wide complex tachycardias, is contraindicated in patients with a prolonged QT interval because it can further lengthen the QT interval and potentially induce torsades de pointes, a life-threatening arrhythmia. Always carefully assess a patient's baseline QT interval before considering procainamide. Question 23. A patient in PEA, pulseless electrical activity, is being managed. Besides high-quality CPR, what is the most important drug to administer? A. Amiodarone. B. Atropine. C. Epinephrine. D. Adenosine. Answer C. Epinephrine. This question asks about the primary drug for PEA. The condition pulseless electrical activity combined with the need for most important drug points to epinephrine. Epinephrine is the primary medication for all non-shockable rhythms, including PEA and asystole, in cardiac arrest. It is administered at 1 mg 4/IO every 3 to 5 minutes to improve coronary and cerebral perfusion during CPR. For example, in a patient with an organized electrical rhythm but no palpable pulse, epinephrine is administered while the team searches for reversible causes. Question 24. What is the recommended administration route for the initial dose of adenosine in stable narrow complex tachycardia? A. Slow 4 push over 2 minutes. B. Rapid 4 push over 1 to 3 seconds. C. Continuous 4 infusion. D. Intramuscular injection. Answer B. Rapid 4 push over 1 to 3 seconds. This question specifically addresses the technique for administering adenosine. The key phrase, rapid 4 push over 1 to 3 seconds, is vital for its effectiveness. Adenosine has an extremely short half-life, less than 10 seconds, so it must be administered as a very rapid 4 push, followed immediately by a 20 ml saline flush, and the arm should be elevated. This ensures the drug reaches the heart in a concentrated bolus to transiently block the AV node. Administering it slowly would allow the drug to metabolize before reaching its target, rendering it ineffective. Question 25. What is the maximum total dose of atropine that should be administered for symptomatic bradycardia? A. 1 mg. B. 2 mg. C. 3 mg. D. 4 mg. Answer, C. 3 mg. This question tests your knowledge of the total cumulative dose for atropine. The concept is to avoid excessive cholinergic blockade. The maximum total dose of atropine that should be administered for symptomatic bradycardia is 3 mg, given in 0.5 mg increments every 3 to 5 minutes. Doses exceeding 3 mg are unlikely to be more effective and may cause unwanted anticholinergic side effects. Keeping track of the cumulative dose is important for patient safety. Question 26. Which medication is a beta blocker that can be used to control ventricular rate in stable atrial fibrillation or flutter? A. Lidocaine. B. Amiodarone. C. Metoprolol. D. Digoxin. Answer, C. Metoprolol. This question asks about a specific class of drugs used for rate control in stable arrhythmias. The keywords beta blocker and control ventricular rate in stable atrial fibrillation or flutter directly point to metoprolol. Metoprolol is a commonly used beta blocker that slows the heart rate by blocking beta-1 receptors in the heart, thereby reducing the ventricular response in conditions like atrial fibrillation with rapid ventricular response. For example, if a patient is in stable atrial fibrillation with a heart rate of 130 bpm, metoprolol might be administered to lower the rate. Question 27. When considering fibrinolytic therapy for STEMI, what is the most important time window for its administration? A. Within 30 minutes of symptom onset. B. Within 60 minutes of symptom onset. C. Within 12 hours of symptom onset. D. Within 24 hours of symptom onset. Answer, C. Within 12 hours of symptom onset. This question addresses the critical timing for reperfusion therapy in acute myocardial infarction. The concept being tested is the optimal window for fibrinolytic administration to maximize benefits. Fibrinolytic therapy, like alteplase, is most effective when administered within the first 12 hours of STEMI symptom onset, with the greatest benefit occurring within the first 3 hours. Beyond 12 hours, the benefits diminish significantly compared to primary percutaneous coronary intervention, PCI. Time is muscle, and timely administration is key to salvaging myocardial tissue. Question 28. What is the typical initial dose for an intravenous infusion of dopamine in symptomatic bradycardia? A. 0.5-2 mcg/kg/min. B. 2 to 20 mcg/kg/min. C. 20 to 50 mcg/kg/min. D. 50 to 100 mcg/kg/min. Answer, B. 2 to 20 mcg/kg/min. This question tests your knowledge of dopamine dosing for symptomatic bradycardia. The keywords intravenous infusion of dopamine and symptomatic bradycardia are the core of the question. The recommended initial dose for a dopamine infusion in symptomatic bradycardia after atropine failure is 2 to 20 mcg/kg/min, titrated to patient response to achieve an adequate heart rate and blood pressure. This dosage range primarily stimulates beta-1 and alpha-1 receptors, increasing cardiac output and systemic vascular resistance. Remember, the goal is to improve perfusion, so titrate the dose carefully. Question 29. A patient is in cardiac arrest. After one dose of epinephrine, the rhythm remains VF. What is the next drug administration after the next defibrillation attempt? A. Atropine. B. Adenosine. C. Amiodarone. D. Sodium bicarbonate. Answer: C. Amiodarone. This question tests the sequence of drug administration in a shockable cardiac arrest rhythm. The key is rhythm remains VF after an epinephrine dose and defibrillation, indicating refractory ventricular fibrillation. According to ACLS guidelines, after initial defibrillation and epinephrine, if VF/private persists, an antiarrhythmic like amiodarone, 300 mg 4/IO first dose, should be administered after the subsequent defibrillation attempt. Amiodarone helps to stabilize the myocardial electrical activity and increase the likelihood of successful cardioversion. It's crucial to follow the cardiac arrest algorithm precisely. Question 30. Which medication is administered for patients with stable wide complex tachycardia that is regular and monomorphic, if adenosine fails to convert it? A. Magnesium sulfate. B. Lidocaine. C. Diltiazem. D. Digoxin. Answer: B. Lidocaine. This question describes a specific scenario for an antiarrhythmic. The key phrases stable wide complex tachycardia, regular and monomorphic, and adenosine fails direct you towards lidocaine. In stable wide complex tachycardia, especially if regular and monomorphic, and if adenosine is ineffective or the rhythm is suspected to be ventricular, intravenous lidocaine, initial bolus of 1 to 1, 5 mg/kg, can be used to suppress the ventricular arrhythmia. Lidocaine acts by blocking sodium channels and reducing myocardial excitability. Remember lidocaine as an option for stable wide complex rhythms when other interventions aren't effective. Question 31. What is a common side effect of rapid adenosine administration that patients often describe? A. Severe headache. B. Chest pain/discomfort and shortness of breath. C. Abdominal cramps. D. Numbness and tingling in extremities. Answer: B. Chest pain/discomfort and shortness of breath. This question asks about a common, transient side effect of a specific rapid-acting drug. The key is rapid adenosine administration. Due to its temporary cardiac effects, transient asystole or AV block, patients often experience a feeling of chest pressure, discomfort, or shortness of breath and anxiety during and immediately after adenosine administration. It's important to warn patients about these anticipated sensations before giving the drug, as they are usually short-lived. This awareness helps reduce patient anxiety during a critical procedure. Question 32. In the management of ACS, what is the role of oxygen administration? A. Routine for all patients with chest pain. B. Administer only if SpO2 is less than 90%. C. Administer only if SpO2 is less than 94%. D. Administer only if patient is dyspneic. Answer: C. Administer only if SpO2 is less than 94%. This question tests the current guidelines for oxygen use in acute coronary syndromes. The key concept is ACLS Drugs Review for ACS, and specifically the role of oxygen. Current ACLS guidelines recommend oxygen administration only if the patient is hypoxemic, oxygen saturation less than 94%, dyspneic, or has other signs of heart failure or shock. Routine oxygen administration to normoxemic patients with ACS is not recommended and may even be harmful. For example, if a patient's pulse oximetry reads 96%, supplemental oxygen is generally not needed. Question 33. Which medication is indicated for the treatment of severe, persistent hypotension, shock, after fluid resuscitation, particularly if associated with reduced systemic vascular resistance? A. Dobutamine. B. Dopamine. C. Epinephrine. D. Norepinephrine. Answer D. Norepinephrine. This question focuses on the appropriate vasopressor for specific shock states. The keywords severe, persistent hypotension, shock, after fluid resuscitation, and reduced systemic vascular resistance are important clues. Norepinephrine is a potent alpha agonist, vasoconstrictor, with some beta-1 effects, making it an excellent choice for septic shock or other distributive shock states where systemic vascular resistance is low and blood pressure needs to be significantly elevated after initial fluid boluses. For instance, if a patient with septic shock remains hypotensive despite receiving 4 fluids, norepinephrine infusion is typically initiated. Question 34. What is the initial intravenous fluid bolus recommendation for an adult patient in hypovolemic shock? A. 250 milliliters. B. 500 milliliters. C. 1 liter. D. 2 liters. Answer C. 1 liter. This question assesses the initial fluid management in a specific shock state. The key phrase hypovolemic shock indicates the need for rapid volume replacement. The initial intravenous fluid bolus recommendation for an adult in hypovolemic shock is typically 1 liter of crystalloid, which can be repeated if the patient remains hypotensive and shows signs of ongoing hypovolemia. This rapid fluid administration aims to restore intravascular volume and improve tissue perfusion. For example, a patient with significant bleeding would immediately receive a 1 liter fluid bolus while further assessment is ongoing. Question 35. After successful defibrillation for VF, a patient has a stable rhythm but remains hypotensive. Which medication could be used as a continuous infusion to support blood pressure? A. Adenosine. B. Atropine. C. Dopamine. D. Lidocaine. Answer C. Dopamine. This question describes a post-resuscitation scenario requiring hemodynamic support. The concept is maintaining perfusion after return of spontaneous circulation. If a patient remains hypotensive after successful defibrillation and achieves a stable rhythm, a vasopressor like dopamine can be initiated as a continuous infusion, e.g., 5 to 20 mcg/kg/min, to support blood pressure and improve cardiac output. Dopamine is often chosen for its ability to increase contractility and cause vasoconstriction. Always remember to treat underlying causes of hypotension while providing vasopressor support.